This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're delighted that you're with us today. And today we want to talk about HIV, the treatment that's currently being done and future innovative care. We're delighted we have once again with us Dr. John Carlo. He's a physician, and he also is the Chief Executive Officer of Prism Health, North Texas. John, welcome back to the show.
Steve, thanks for having me back, and it's good to be here.
John, globally, nearly 80 million people have been infected with HIV since the start of this epidemic back in 1981, and at least 33 million people have died. In the United States, about 700,000 people have died since the beginning, and now we have 1.2 million people living with HIV in this country. Why do you think that there's not more awareness about this pandemic today?
Well, it certainly is remarkable, especially with these numbers. You know, as certainly as we're tracking the coronavirus numbers. When you look at these, you just have to, realize, wow, this has been a global devastation, and it is surprising that there's not more awareness today. I think that it's two things. One is it is our attention span, and we're not the most long-range attention span people today. And finally, I think it's not we don't have visible representation anymore, and this is certainly a good thing. We've got great treatment today. But this sort of makes it go silent. And so we don't have that visual, thankfully, anymore like we saw in the 1980s.
I remember when, like Arthur Ashe and some of the premier athletes, and of course, Magic Johnson, you are right. Sometimes we have short-term memory. And hopefully, as we focus on COVID-19, we won't forget about HIV, and we will realize that this is truly an epidemic also.
Yeah, I agree. And I think we are sort of programmed to sort of move on, and it's probably evolutionarily beneficial for us to kind of forget a little bit, especially when we have to deal with these huge challenges. So I think you're right. Let's not forget, especially with coronavirus, as we move on. Same thing. We've got to keep remembering that these things continue to be a part of our world, and they still are a problem today.
Many of our listeners may have visited the Presidential Library of George Bush right here in Dallas. But as you know, a large portion of that library focuses on the President's Emergency Plan for AIDS Relief, which President Bush signed in 2003. Why do you think President Bush considers this to be one of the best and greatest achievements during his presidency?
Well, it certainly is remarkable, and I have to admit I was delightfully surprised when I walked through the library and saw such a large component of his library dedicated to PEPFAR, especially when his presidency was marked with so many other things like 9/11 and Hurricane Katrina. But, I think it says an important message. First, that the public health component is certainly bipartisan. And this is something that is not divided by one political side or the other. And I think President Bush got that very, very significantly. He had been moved from the very beginning about the devastation in Africa due to HIV and AIDS, and had really wanted to do something from the very beginning. It is one of the most remarkable achievements. It was a huge accomplishment, resulting in $80 billion that first year going to nations where there was entire villages and cities being wiped out. So it really is, I think, one of the greatest achievements of this country in addressing what was at that time just an unaddressable condition. And it really spurred out a lot more investment, thankfully. And we've done an amazing amount of saving lives thanks to this.
As you look across the United States, and let's kind of pull it in domestically, what would you say are some of the accomplishments since the onset of this epidemic? But what do we still need to do?
Well, I think this is an interesting time to reflect on the successes and how we're doing domestically. Just like the global effort of PEPFAR, we had a domestic effort called the Ryan White CARE Act, which was enacted in 1990. And it really represents really one of the few conditions or diseases that we in this country have specific support from a federal all the way down that really enables care for this disease condition at a level that's really unmatched. So this is really a remarkable achievement that continues today. And, we've made a difference. We certainly have reduced the number of new infections substantially, particularly in areas like New York and San Francisco. Remarkable achievements in the number of cases, and really the survival is also remarkable today, thanks to the tremendous innovations around the treatment. But, we're not done. And being here in the South is one of the bigger problem areas. And we're still seeing new cases here at rates that we don't want. And we still see new infections, far too many. And especially in our younger communities, in our communities of color, we've still got a lot more work to do. But, I think there is some achievements that we certainly can celebrate at this point.
So if we come to, say, North Texas, here in the DFW area, how is it locally? And what would you describe as our current situation?
I think North Texas and Dallas is where we're experiencing the HIV epidemic. It's not different than what we're seeing with the coronavirus epidemic as well, unfortunately. And I think that there is tremendous parallels. Unfortunately, just about every time you look at case rates by zip code, it almost always maps with all of the other conditions and challenges that we have around health inequities in this area. So, we know our zip codes to the south are perpetually challenged with not only HIV and AIDS, but increased coronavirus infection rates, hypertension, diabetes, all of those conditions, it's all bundled together. And Dallas is not really any different than many large urban areas, particularly in the South, that we just have huge health inequities that really fuel continuing cases of HIV and AIDS in certain communities. And this is really where we've got to keep moving and really continue to try to address.
What are some of the common risk areas associated with HIV?
There are still myths out there that you can get HIV from sharing utensils or other types of things like that. There is some misperception that still remains today. The main ways HIV is transmitted from person to person today is really two things. One is sharing injection needles. And this happens, of course, around drug abuse and use in the community. And secondly, it's unprotected sex. And, it's important to note that it wasn't always just those two. We thankfully got rid of the risk from blood transfusion and maternal to child transmission. So we've actually accomplished quite a bit, but we still have these two factors that do result in continuous new infections.
And we're going to keep this conversation going with Dr. John Carlo from Prism Health, North Texas, including when we come back, the latest new treatment that's been approved by the FDA. That's next. Stay with us on the human side of healthcare.
This is the human side of healthcare on 1080 KRLD and the radio.com app, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're going to jump right back into our conversation with Dr. John Carlo. He's been with us before. We're welcoming him back again to talk about HIV. Dr. Carlo is also the CEO of Prism Health, North Texas.
We've seen that the FDA approved a new HIV treatment. Can you tell us what that treatment is, and is it going to really impact infection rates?
Sure. This is something we are very excited about. This is a new HIV treatment called Cabenuva, and it, unlike our current HIV treatment, which really relies on pills that you take orally, this is actually an injection that you can supply, and we will probably be able to do this effectively once every 2 months. And so rather than somebody having to stay on medications and take them every day, this is actually an injection that actually works just as well. And really, I think it has a lot of potential around, particularly for those that have trouble keeping up with daily medications for many reasons. The simplest reasons, maybe you just don't want to swallow pills, but even more complicated reasons like privacy issues and not having a safe place to store medications at home, or fear of having that medication found. So there's really a lot of potential with this, I think, in addressing some of the specifics around where people are challenged in keeping up with their medications. But the big question I have, and I think we all have, is what is this going to do, this additional tool, in resulting in lowering the epidemic conditions even further? And that's really the big question we don't know right now. Is this something that will prove to be better than what we currently have in terms of the great treatments we have? Will it result in fewer cases because somebody on this treatment will virtually be uninfectious or really zero risk to anybody else? So, a lot of opportunity I see, and a lot of potential. But I think we've got to learn more. And one of the things I'm looking forward to is, implementation science studies that are going to really look at where this treatment can be best used effectively, and what can we learn from it. So very, very exciting.
There have been a lot of efforts over the years to help eliminate the HIV epidemic, some more successful than others. Do you think we can glean from some of this information on how we can apply some of those efforts to other diseases and conditions? For example, COVID-19.
Yeah, and I think this is a great question today. And first, thanks, Steve, for being involved as the representative of the hospital council on these efforts in this community. This is one of the things we've been focused on is ending the HIV epidemic by using the tools that we have, which includes great treatment, great testing, and what we needed is raising awareness and really reaching more people. So these efforts are underway in cities across the country, and they've proven to be very successful. And I think this is something we can learn from, particularly what we're challenged with right now with COVID-19. You have very similar circumstances. You have suspicion around the vaccine. You have a challenge in getting the vaccine out as quickly as possible to higher risk individuals and reaching those folks effectively. These challenges are not new. These are the things we had to tackle with the HIV epidemic, and what we've learned from that is a couple things, that you cannot have enough resources on the ground that understand the community. And that, I think, is one of the things that's really been valuable for our team and our case managers and people. We're walking the blocks, we're out in the community, and we're looking like those that we're serving. So we are the messengers for the message, and I think there's a lot to be learned in how we've been able to accomplish this that could be useful for what the challenges we have today with coronavirus.
That's a great insight that you've given us. Are there other parallels that you think exist between COVID-19 and the HIV pandemic?
Yeah, I think that the biggest connection, and this is not unique to either of these pandemics, it's also what we saw in 1918, is that while we're all equally susceptible to all of these viruses, there's really nothing different between human beings as to why one might be at more risk than the other. What we're finding is the impact of suffering is not certainly equal across our community. And, this is a distinct parallel that we can see with HIV and coronavirus, is that, there are communities that are disproportionately being impacted from both of these conditions. And, I think the big misperception, the thing we've learned the most around HIV is you really got to be on point about how you talk about these health disparities, because messaging and the words matter at this very junction. And as we talk about it from a standpoint of who is at risk, oftentimes we push into the term race and ethnicity as something that might be the risk factor. And it's really not the case for either of these conditions. Being African American or a person of color does not put you at higher risk just by the very nature of your skin color to either of these conditions. But there is a perception that has been created because of the messaging. And so I do think that there is a lot of parallels, unfortunately, in many ways, about how we talk about these conditions and how we address it and how we treat it and how do we make sure that we're making our community safe.
As we look at the HIV pandemic and you look in your crystal ball, as you look to the future, what do you think we can expect?
Well, I think there is certainly hope. I think we have done a remarkable job at having just incredibly effective treatment. Right now, if we reach people and they stay in care with us today at our health centers, we really talk about having a normal life without symptoms and a normal lifespan. And that's truly a remarkable achievement that we have today, and it's worth celebrating. But we're certainly not done. And I think that the challenges now become greater, I think, as we start really trying to address the ending of the epidemic itself. And, we're really going to have to work even harder to reach those that are harder to reach. At a time, as what we talked about at the beginning, there's certainly complacency around the situation altogether. And, I think that's the hard part. When you start, losing the attention span, but yet there's still a problem, that's when it's hard to get that momentum. And, it's something I think we're all recognizing. And hopefully we don't see a parallel again as the coronavirus, we get it more and more under control. We've got to worry about that similar pattern of complacency and really making sure that we don't repeat those types of things going over and over again. So I think there's hope. I think that, there's a tremendous amount of success that has happened. I think the future is around vaccine. I think the future is around even greater and more effective prevention. And I think that the future could look like where we don't see an epidemic of HIV on the planet, and it certainly is possible, even in this generation. So I'm very hopeful that we'll be able to see that.
And on that very note, we wanted to ask Dr. Philip Huang, he's the director of the Dallas County Health and Human Services, about some bold moves that are going on in North Texas to deal with HIV.
Dallas County and City of Dallas signed on part of an international movement to be a fast-track city and county to end the HIV epidemic. And so that really commits our community to trying to accomplish some very specific goals. We have to talk about 90-90-90 by 2030, where 90% of all persons living with HIV will know their HIV status. 90% of those persons will be on sustained treatment, and 90% of those persons will be virally suppressed. And then we're also looking at some targets. Now it's moving to 90% reduction in new cases by 2013 and eliminating this negative stigma that is seen with HIV. And so, we're really we're bringing a lot of community partners together to work on this collectively in the areas of prevention and preventing new infections, testing, and rapid linkage to care. So getting people tested so they know their status to accomplish that first 90% goal that we have, and then getting people rapidly to treatment. It's a very different now experience for people. It used to be people might be told, okay, tested, and then told, hey, your test just came back positive for HIV. Come back in a few weeks, and But now we can say, well, your test just came back positive for HIV, but you can start treatment immediately. And in 48 days or so, you can be virally suppressed and you can expect to live a normal life. But so it's a very different message that is able to be given now.
A guy that I went to school with passed away in his 30s. I think of what he and his family would have loved to be able to hear what Dr. Huang just said. Dr. Philip Huang and Dr. John Carlo on this very important topic and how we are making incredible progress. Thank you both for joining us. Now we're going to swing down to Parkland Health and Hospital System next and talk to the Chief Nursing Executive, Karen Watts. She has some amazing behind-the-scenes stories of what her nurses have been going through treating COVID-19. That's next on the Human Side of Healthcare.
The DFW Hospital Council, along with our over 90 member hospitals in North Texas, are proud to bring you the human side of healthcare with Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome to the human side of healthcare. We're delighted you're with us today. And we decided today we wanted to talk to someone who's an expert dealing with the nurses that have done such heroic work during COVID-19. We're delighted to have Karen Watts, who is the Chief Nursing Executive at Parkland Health and Hospital System with us. Karen, welcome to the show.
Thank you. I'm happy to be here.
Well, we're going to jump right in. We've been hearing a lot and dealing with COVID for almost a year. Parkland is a large health and hospital system. How many Parkland nurses have been directly involved in caring for the hospitalized COVID-19 patients?
Well, I could probably not give you an exact number, but I would say it's in the close to 2,000 nurse range.
That is amazing to have 2,000 people that have been doing that, and what heroes they are. Do you have any idea how many have been assigned directly to COVID units throughout the entire pandemic?
I really don't know exactly. When we started, we had, one COVID unit to start, and then currently we have probably about 6 or at least 6 COVID units now. So it's altered somewhat and difficult for me to get exact numbers because when we started universal testing here some months ago, we test everybody that comes in that's going to be an admission for COVID. Therefore, COVID patients can be in different units outside of the regular COVID units if they're asymptomatic.
Yeah, that makes sense. And, when you think of it, though, at least 2,000 of these heroes have been treating these patients. This has got to take a toll on people. How are the nurses doing, in your opinion, after a full year almost of battling COVID-19?
Well, I think when we started to decline somewhat from the summer in July, I felt like we were catching our breath and people were starting to feel better. The nurses and providers and others, physicians, were starting to feel a little relief. And then as the numbers peaked during the latter part of this year up until now, even though we've stabilized somewhat at this point, I think it is really just weariness. I see a lot of weariness. I see compassion fatigue. I see stoicness around continuing on this mission to take care of these patients. One of the things that has happened here as our numbers had climbed is we had two areas or two pod areas that we had patients that were COVID positive had been closed at one time. When we had to go back and open those 2 pods, it was a heaviness. You could just feel it in the air. Oh no, we're going back to a space where we had patients before. And the staff remember the ones that died. They remember where they were located. And it was almost like going back in and reliving some of those moments that were so difficult, tear-filled, trying to work with families that could be present. And we had to use technology to do everything from give last rites to families to be able to communicate with patients. So it's a heavy burden.
It really is. And, to our listeners, to help them really understand, can you describe kind of the daily life of a COVID ICU nurse and what they go through?
Well, I think and I'll go back a little bit to when we first began with COVID, and as we were learning, of course, there were many moments of trying to understand what this was going to look like and what it was going to mean. And so we would have different groups of nurses, critical care nurses, coming together from multiple critical care units. So you may normally work in the medical ICU, but now you're in the COVID ICU, or you're normally in the burn ICU, and now you're in the COVID ICU. So pulling people from different areas that hadn't worked together before, that was a challenge for us at the beginning. Now that we're much deeper into it and we're a year of practice with all of this, it's better because they do know their team members generally, but we still have quite a few people that float in there. So if you're coming into work and you start your shift, you know that you're going to have some of the same people that you're used to seeing, and you'll also have some travelers and others that would be helping. Of course, you have to do the donning and doffing and wearing protective gear continuously. You all have seen probably on the news many times sometimes the faces of nurses and doctors and others, respiratory therapists and so forth, that wear our N95 mask, it does some damage to the skin. Sometimes it dries it out. It's hard to be in a mask like that every day and try to communicate with patients. People cannot see each other's faces, so how you identify yourself as you walk around during the day is as you wear your face shield. We usually put our names on the face shield so that you know if this is a person you may not work with regularly, you would know who you're working with. And that includes anybody that's working in those units. So that is difficult in some cases because everybody somewhat looks the same just because of what the way they're dressed. I think the other thing is just the fatigue factor during a day when you're donning and doffing and you're having to protect yourself as well as protect the patient every day. It is tough. Sometimes it's hot in there. You need some breaks, like really hydration stations where you can, take a break, get out of your donning and doffing clothes basically, and then take a break and have lunch or drink and hydrate yourself. In COVID units, you can't generally have drinks near you. Like if you were working in a regular critical care unit, you could in the lounge area have your water as long as it's covered and protected, and you could go in there and drink it and be in and out. But if you have to go for hours, if you have a really sick patient you can't leave, you're not hydrating yourself very well. So I think that's a struggle. Also, when we have COVID in other units, we would don and doff for each patient in and out. But in the COVID ICUs, it's a little bit different in how they manage it. So I would say it's tiring, it's hot, the impersonalization of having the masking and the shielding and so forth is difficult. On the flip side of that, as a nurse in an ICU in a COVID unit, there's a lot of camaraderie. There's a lot of teamwork. Everybody's in it together. People help each other. They care about each other. When you ask for help, you get help. It is a very much a team effort. One of the things that they face in the ICUs with COVID is we do a lot of what's called prone ventilation, and that's where the patient lays on their stomach to try to help protect their lungs, and it's one of the treatment modalities that we use for COVID patients. I think treating patients that are in a prone position obviously has its challenges. So you could come in during a shift and you may have prone patients, or you may not. You may have some patients that are on what we call high flow oxygen. They are very risky. The COVID patients, we find sometimes as we take care of them, they can decline rapidly, even though they may look like, okay, they're holding their own right now. Very quickly, they can start to deteriorate. So your skills and having to be on your game continuously is there. That would be true in any nursing unit or any critical care unit, but particularly with this patient population, it's a struggle. And I think also there are pieces that are different for those in the COVID units and trying to communicate with the families, because obviously you can't have regular visitation. In that case, you have everything from Zoom calls to, we'll have iPads on wheels where the families can talk to the patients, and we try to make sure that they're communicating and supporting them. The physicians are rounding and looking at the records and talking to the staff, and we're just a really strong team of people. And I would say the camaraderie among people who have worked in these units is exceptional.
That's amazing, and you've certainly given a description to our listeners of what the real strain and stress is working in a COVID unit. Let me ask you this, Karen. From a nurse's point of view, what have been some of the biggest personal challenges of being involved in treating COVID-19 patients?
Well, I certainly think when we started, we didn't know what we didn't know at the time. We were protecting ourselves and using our protective gowns, gloves, masks, face shields, and so forth. But at the time, we really didn't know how much we could limit transmission. So we got better at that and realized if we protected ourselves with protective, exterior devices, including the face shields and the mask and so forth, that we could be safe. So I think the fear factor at the beginning was very high. So if you were going home to your family, you may be worried, am I carrying COVID home to my family? So early on, as we had nurses work in these units, if they had small children, babies, families, or elderly parents with them, they were hesitant about going home, staying there, how they would protect themselves from their family for the risk. What if I contract COVID? Now, that proved not to be really the risk that we thought it was initially. So that helped. So I think over time, personally, it's gotten better. But I would say many of our nurses would, as they come here and they dress out, and then they go home, they would probably stop in their garage or wherever they enter their home, change clothes immediately, take a shower, making sure that they're just clean and they're protecting their family. I think that has been really tough for so many of them, worried about their own families and could they potentially bring home anything that could hurt their families. I would say that would be one of the greatest personal challenges. I would say also their families being scared. You got, it could be a wife, a mother, a sister, a brother, whomever it is, your family would be worried about you. You're working in a COVID unit. What does that mean? I'm worried about you. So I think as a nurse, many of the family members were scared of what could happen to the nurse. Could the nurse get sick? Could the nurse be exposed? What does this mean? So I think just really a lot of fear. We're a lot more knowledgeable today than we were when we began, obviously, because we've learned so much. But at the same time, there's still the, you have to be on your game. You have to protect yourself and make sure that you are protecting yourself personally so that your family is protected as well.
We are going to take a quick break and come back, talk more with Karen Watts about some of the things that have been going on behind the scenes at Parkland Health and Hospital System. Before we go, I'd like to remind you of our podcast. It's on all the major podcast players. You can catch our episodes and these great interviews of what's going on in the Dallas-Fort Worth, North Texas area from the healthcare perspective. It's on all your major podcast players. The Human Side of Healthcare podcast. Stay with us. We'll be right back.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environment. This is the Human Side of Healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
Welcome back to the Human Side of Healthcare. We're continuing our conversation with Karen Watts. She's the Chief Nursing Executive at Parkland Health and Hospital System. These healthcare workers in North Texas and all over the country are unsung heroes during this past year. Can you imagine how exhausting this past year has been for them? And the one thing that we've repeated on this show is please just wear a mask. And when healthcare workers see people not wearing a mask, we wonder what they might think.
What does it mean to nurses, in your opinion, when they see people who refuse to wear a face mask, they won't physical distance, and they don't do anything candidly to help stop the spread of COVID? How do nurses react to that?
I think it's frustrating for the nurses to see that. When you work daily with patients who are prone ventilation patients, patients who are very unstable, patients who are dying from COVID, it is hard to watch the news and see what's going on across the country when you yourself are working with these patients and know the risk. So it's very hard to have people who say, well, there isn't such thing, or they deny it, or they don't want to wear the mask, and they're really resistant to what we could do to mitigate the risk. It's very hard. And the less people in the community and throughout the United States do not mitigate the risk, then the more admissions obviously we have, which you see from the data, Steve, that you have. So I think the nurses and really all of us hold our breath when any event is going to happen, whether it was Thanksgiving, Christmas, New Year's, now Super Bowl. We hold our breath to wonder, are people going to protect themselves? Are we going to see another surge? What would that surge look like? How many more deaths would we see? It's hard. It's hard every day, day in and day out, to do the work and then to realize that we never know when the next surge is going to come. And part of that is due to how people do not protect themselves.
Let's look at something a little more positive. The arrival of the COVID-19 vaccines. How has that changed the outlook of healthcare workers and specifically nurses?
I remember the day that we started the vaccines for the Pfizer vaccines here, and the lines, we had set up for our employees to come get the vaccines, including, of course, the nurses are in line as well. We walk those lines, myself and many other leaders here, and talk to the staff along that line. And the mood was, you could feel a much lighter mood. You could feel hope. It was tangible and palpable that people felt, finally, we're going to have a chance to fight this. We have a chance to really vaccinate as many people as possible, and it's going to protect healthcare workers, which will thus protect further into the community and beyond. It was really exciting. I saw more laughter, more smiling faces, just a lot of happiness around it. So the vaccine definitely has been a ray of hope, especially as our numbers had peaked.
You know, it's amazing also on the vaccines. Thomas and I had the privilege of interviewing Vivian Johnson from Parkland, and she talked about how one of her missions was to ensure that people weren't afraid to take the vaccine, and especially people of color. Do you have thoughts on the efficacy and safety of vaccines?
We all as a group feel that the efficacy and the safety of the vaccine is solid. We've spent enormous amounts of time looking at it, including Vivian and her team, physicians and others. So we feel confident about the vaccine, and of course would never try to get others to get a vaccine that we ourselves did not support.
You know, Karen, I'm going to pivot just a little bit because we've been talking about the bedside nurse, our healthcare heroes. But in your role as chief nursing executive, you have a tremendous amount of administrative work, planning the staffing, looking at the ratios, looking at how you deliver the care. So I'm going to ask you, we constantly hear about bed capacity. We hear a lot about PPE, but I think our listeners need to understand, how did you deal with nursing shortages, especially during the peak periods of treating COVID?
That has been a challenge for us from the beginning of as our numbers started to climb. One of the things that we saw that added to the need for more staff, when COVID really started to grow and the volume started to grow, what was immediately obvious is we needed more critical care beds added. So really, we have grown in our critical care bed numbers, and we've probably added about 91 critical care beds, as well as many other med-surg and step-down beds around COVID care. That then required more nurses, particularly critical care nurses and nurses that are comfortable with various modalities for critical care patients. The acuity level of these patients is very high, and our intensivists would tell you it's some of the sickest patients they've ever taken care of, the ones that are really, really critical. We have worked with traveling agencies, obviously, to bring in extra staff to supplement our staff. The other thing that we've been fortunate with is the state Regional Advisory Council provides support for us to have nurses that are called RAC nurses, and they're basically critical care or sometimes med-surg nurses, and that's true on respiratory therapy too. We get some help from there. Those nurses have helped to supplement our staffing, and that's been a huge help for us. That also has helped us to increase the criticality of our beds and have more people to provide care. We've been fortunate that we have had that support in the state of Texas. Not every state has the support that we have had here. We were able at Parkland early on to start working with the RAC to be able to get the additional help that we need. That has helped. We've also done extra shift pay for those to pick up extra shifts to help cover it. We've been able mostly to maintain our nurse-patient ratios. There have been some shifts where we may have been short and we had to do some team-based care, which would have altered what our normal process would be, but it's safe and effective, and certainly it's been used throughout the country during the pandemic. But I feel with the help of the state and with the traveling agencies, we've been able to really supplement our staff fairly well.
You know, you mentioned a term there that Thomas and I know what it is, but our listeners may not. Can you define for our listeners what a traveling nurse is?
A traveling nurse is a nurse who usually has experience. It could be a few years to 20 years, and they make a decision that they want to go travel around the country, work other places. There's additional pay, and you get to travel and see places that you might not otherwise have experienced. So many nurses do traveling assignments, In the United States, because, there's always shortages of nurses throughout the United States, in particular pockets, they normally get utilized and assigned in areas where there's less available nurses in the country. In the case of COVID, the traveling nurse agencies have grown exponentially. They have added many, many more nurses to the traveling ranks. Many nurses have left health systems to go travel because there's significant increase in salary to be able to do that for a period of time. Now, some people do not like to travel. Obviously, not everybody wants to leave their family, or if you have small children, that's probably not a choice that you might make, but it is a choice for many others. And so traveling nurses are used to really help around the country in those areas that particularly are short. And COVID has really grown that whole business substantially.
And then you were talking about young people and advising young folks. From your path in this profession, what is your advice to that parent who might be listening, who has a teenager, who might be considering medicine, or maybe the kids are actually listening themselves? What would you tell them?
I would tell them that this is a great profession. It is full of possibilities. It is full of different tracks that you can go on and learn how to provide care for patients. Nursing is a very extensive profession, and you can touch so many lives. You really are witness to the most intimate moments in a patient's life as they go through whatever their challenge is. It could be having a baby all the way to a COVID situation and anything in between, a clinic. Our people giving vaccines at the off-site locations that we provide vaccines. Those patients that drive through there, they're so grateful. It is really heartwarming, and I would say you would never regret going into a field like nursing, that really you can work in so many different arenas, but in general, our patients are so grateful for what we do for them. It is really very rewarding.
And nursing is one of the most in-demand and most rewarding careers one could have. Karen, thank you for the insights behind the scenes. What a week it has been in North Texas. We hope that you, your loved ones, your pets, and your property are safe. Have a good thaw out, and we'll see you here again next week on the Human Side of Healthcare.